Okay, great. So here's what we're going to do here, or I'm going to do here today. The first thing is just to look at what is the conception of psychiatric disorders that our society has organized its thinking around for the past 43 years. It's often called a medical model, but in fact, it's a disease model. Hold on, I just need to change one thing. Okay. It really is a disease model. So we'll look at what were the origins of that disease model, whether it was founded in science or whether there was basically guild interests. By guild, I mean the American Psychiatric Association behind this adoption of a disease model. Then we're going to look at, secondly, we'll look at how the pharmaceutical industry was so pleased with this disease model because they knew that it would expand the market for psychiatric drugs, and how there was a merger of interest between the Guild, American Psychiatric Association, and pharmaceutical companies. And we'll look at how that affected the story that was told to us. The next, we'll look at real briefly the public health outcomes with this form of care. And then we'll spend a bit more time looking at the long-term outcomes for people diagnosed with psychotic disorders and treated with antipsychotics, and then also diagnosed with depression and treated with antidepressants, because that part of the story will tell us whether this model, which emphasizes drug treatment as a first-line therapy, what is the evidence base for it? How does it affect people long-term? And then finally, after we've been through that, we'll really see at this point that this disease model has failed from every sort of point of view. And that opens up the question, which is being raised by many people today: what type of model of care could replace this disease model that we've had for the last 43 years? Okay, so now I have a problem with my thing. Why is it not working? There we go. So this was what I was just talking about, what we're going to talk about, how this talk's going to be organized. We're going to look at the DSM-3, what was the birth of it. Then we're going to look at the merging of guild interests and pharmaceutical interests. And then we're going to see how that merger of interests corrupted the narrative that was told to the public. And in fact, how it was out of sync, that narrative, with what actually the research was showing. So DSM-3, that's the Diagnostic and Statistical Manual published by the American Psychiatric Association. They published their third edition in 1980, and that's when they adopted what they called the medical model. But as we'll see, it's really a disease model. And here's a quote by Jeffrey Lieberman, who was the former president of the American Psychiatric Association. He said, DSM-3 was the book that changed everything. And he's correct about that. This changed our conception of what we see as normal, what we see as abnormal. It changed our conception of sort of our philosophy of being, how we respond to the world. We began seeing ourselves as almost under the influence of our neurotransmitters, as if they directed ourselves. And it's going to change how we raise our children as well. So when he wrote this, Jeffrey Lieberman, he wasn't just talking about a book related to change things in psychiatry. It actually changed everything in our society. And at another time, he said it's the most important book that's been written in the past 50 years. And I agree with him in terms of the influence it had on our society, because it did change us as how we think about ourselves, how we think about children, and how we organize our thinking about what to do when we're struggling. So if we go back to the origins of DSM-3, it's going to be presented to us as a scientific advance, but that's actually not what history shows. What history shows is that in the 1970s, psychiatry felt as a profession that it was under siege, and that there was a lack of respect for psychiatrists as being real doctors. And what was the criticism? Well, there was an anti-psychiatry movement that was rooted in actually the academia, in academic settings, that said psychiatry doesn't really function as a medical discipline, it more as a mechanism of social control. That was one problem. A second problem is talk therapy was sort of its bread and butter for people outside the asylum in the 1960s and 1970s. But they were increasingly the preferred form of talk therapy in psychiatry was Freudian-based psychoanalysis. But they couldn't show that their form of talk therapy was any better than the talk therapy offered by psychologists, counselors, and so many others who were setting up shop as therapists. Now, benzos arrive in the 1960s. This is Valium and Librium, mother's little helper. These become the first real popular psychiatric drugs. But by the 1970s, benzodiazepines were being recognized at a government level of being addictive, that they shouldn't be used long term, and that they were causing all sorts of harm. And you had newspaper magazines talking about when these drugs turned on you. We had a psychiatric survivor movement rising up, and this was formed by ex-patients of hospitals who said they wanted to be free of psychiatry. They had survived psychiatry, and now they wanted to be free of psychiatry and its drugs. Then there was a famous study by David Rosenhan, a psychologist, in which he sent himself and 8 of his students into mental hospitals, and as they arrived at the front door, they complained of hearing a word like thud, and they were all admitted. They were diagnosed with schizophrenia, and they were never seen as imposters by the staff of those mental hospitals. And then finally, there was a very famous movie, One Flew Over the Cuckoo's Nest in 1975, which depicted the mental hospital as basically a place of abuse. And actually, maybe the staff were crazier than the patients. And all this produced a crisis. Now, there was a scientific impulse because the diagnoses in DSM-2 were understood to lack validity and reliability. They weren't really very useful. And researchers at Washington University said, we need to start over with our diagnoses, and maybe we can get 20 general categories, and we'll start researching them to see if they're valid categories, valid diagnoses. But that scientific impulse was abandoned based on the guild impulse, the guild need to rebrand psychiatry. And they said to themselves, how are we going to distinguish ourselves from psychologists? How are we going to distinguish ourselves from other counselors? And they said, we need to present ourselves as doctors in white coats, because the white coat, of course, has great prestige in our society. So they said, we need to adopt a medical model and present ourselves as a medical specialty that treated diseases of the brain. Okay, they're going to do this to rebrand themselves. And you'll see Gerald Clerman in 1978, as this is being done, this development of DSM-3 is being done. They said, there is a boundary between the normal and the sick. It is the task of scientific psychiatry as a medical specialty to investigate the causes, diagnoses, and treatment of these mental illnesses. So they're saying these are illnesses of the brain, they're diseases of the brain, but the important thing to recognize here is these were actually hypotheses. There was no science actually identifying them as diseases of the brain, but they adopted this model to rebrand themselves to the American public. And then there was a famous book called The Broken Brain, written by Nancy Andreasen, who was editor-in-chief of the American Journal of Psychiatry. And she presented this new model to the public. And she said, the major psychiatric illnesses are diseases. They should be considered medical illnesses, just as diabetes, heart disease, and cancer are. And now watch this. The thought is that each different illness has a different specific cause. There are many hints that mental illness is due to chemical imbalances in the brain, and that treatment involves correcting these chemical imbalances. Now, this is the story we're going to hear. We're going to hear that researchers have discovered that depression is due to too little serotonin, and schizophrenia and psychotic disorders are due to too much dopamine, and that we have drugs that fix those chemical imbalances, like insulin for diabetes. Now, that's a story, if true, would represent, in my opinion, the greatest medical advance in history, that they had discovered the very molecule that caused madness, or the very molecule that caused depression, and they could fix it. And when I say it would be the greatest advance in medical history, it's because the brain is so incredibly complex. And that's the story we're going to be told. Now, just real quickly, when this disease model was adopted, when it was presented in 1980, the pharmaceutical companies thought this was the greatest thing ever, because what they understood now is so many sort of ordinary problems we have, ordinary problems of living, the unhappiness that sometimes we feel, the worry that we feel, the setbacks we have in life. which we before understood were problems in living, are now going to be classified as diseases. And once they're classified as diseases, pharmaceutical companies can get FDA approval for treating that disease. So, for example, you can't get a pill for treating unhappiness, but you can get a pill for treating the disease of depression. So they're going to be thrilled with this. Now, once they come up with this new model, the American Psychiatric Association says we now have to sell this new model to the public, and they set up all sorts of public relations machinery to sell this story to the public. They set up a new division of publications and marketing. They courted the media, holding media days, telling of great advances in psychiatry. They ran media training programs for psychiatrists around the country, what to say to the press in order to sell this story. They developed fact sheets that were distributed to the press that told of advances in research, how the psychiatric disorders were diseases, and the drugs were safe and effective treatments. And then as new drugs came to market, they partnered with the industry to tell of new diseases and effective new drugs. And just so you can see this, once in 1980, once the American Psychiatric Association adopted this disease model, the pharmaceutical industry is going to start flooding them with money, the APA, to do this PR, to sell this new story to the public. And you'll see in 1980, they gave about $10 million to the American Psychiatric Association to fund its various operations. But then you see a steady increase, and especially an increase when new drugs come to market, like the SSRI antidepressants in 1988, atypical antipsychotics. So they went from 10 million in 1980 to roughly 70 million in 2008. Now, what happened in 2008, Senator Charles Grassley, published information about how much money was being given to individual psychiatrists to promote this new story. And the APA, to sort of save face, had to phase out symposiums, at least for a period of time, at their annual conference that were paid for by drug companies. And that's why you see this drop in revenues. And here are just what I've already talked about. Basically, the pharmaceutical companies were giving this funding to the American Psychiatric Association to sell this new story to the public and to the medical community. And one of the big things were these, quote, scientific symposiums at the APA's annual meeting. You'd go there, and everybody could go to a breakfast or a lunch or a dinner, a free meal. And at the meal, there would be talks by very well-known psychiatrists talking about disease models, about new drugs, the effectiveness of them. And it was seemingly a scientific presentation, but in fact, those presentations were vetted by the pharmaceutical companies who were paying the doctors, the psychiatrists, to give that story. Okay. Now, just to give you an example, so money, we looked at just a second ago about money that was flowing to the American Psychiatric Association. Money was also flowing to individual psychiatrists, prominent psychiatrists at academic medical schools, to be their thought leaders, their key opinion leaders. So they began paying people to put their names on clinical trials, to serve as advisors, consultants, give continuing medical education classes, to give presentations at the APA's annual meeting. And here's an example of what Charles Grassley reported in 2008 of just 4 people who had helped build markets for different drugs. Joseph Biederman was very big in building the market for ADHD drug. He got 1.6, and by juvenile bipolar, he got 1.6 million from one doctor alone. Frederick Goodwin was a former director of the NIMH. He got 1.2 million to help promote a drug for bipolar disorder. The bottom 2 are psychiatrists, child psychiatrists, who help build markets for prescribing drugs for ADHD and juvenile bipolar disorder, and antidepressants, actually. So for building markets for prescribing drugs to children. And this is what I'm just saying. These thought leaders, they're the ones that we as the public rely on. So what do? They serve on task forces that establish the diagnostic boundaries. They conduct clinical trials. Actually, they put their names on reports of clinical trials. The clinical trials are analyzed and summarized by the drug companies themselves. Then they would, put their names on those articles. They would, when the media called, the media would call them to understand the efficacy of new drugs. And they would be the people who would speak about the validity of the new disorders, efficacy of treatments at scientific symposiums, continuing medical education courses, other professional forums. They set the clinical practice guidelines. They write the textbooks, etc. So thought leaders who are being paid by drug companies are going to be the people that sell this new story to the public and tell us that these are real diseases and the drugs are safe and effective. And we're going to be hearing about the chemical imbalance story as well. Now, in 2008, I attended the annual meeting of the American Psychiatric Association, and they had in their guidebook a list of the speakers who had to say how many consulting agreements they had with pharmaceutical companies. And you'll see that 373 speakers disclosed they had 888 consulting agreements with pharmaceutical companies. And 483 were serving on the speakers bureaus, meaning they would go out around the country and help them sell their drugs. So what you see here is basically a capture of academic psychiatry by the pharmaceutical industry. And here's what psychiatrist Daniel Carlat said in 2007. Our field as a whole is progressively being purchased lock, stock, and barrel by the drug companies. This includes the diagnoses, the treatment guidelines, and the national meetings. Now, we in the public think we're listening to, academic scientists as they're telling this story about the disease model. We really didn't understand for so many years that they were working for the drug companies to promote this model. And I did a look at the industry payments to psychiatrists more recently. And here's what I found in 2016, 2017. There's something called the Open Payments Database where you can find this data now. Over half of all active psychiatrists received some payments from pharmaceutical companies in these 2 years or something of value. Total payments during the 2 years of $110 million from industry to 26,000 psychiatrists. 71% was for speaking and consulting fees. These are the people that form public opinion. And the leading guy is someone named Stephen Stahl. He runs a continuing medical education company, and he got more than $3 million during these 2 years. So what we just saw is that following the publication of DSM-3, pharmaceutical companies, well, number one, the APA itself wanted to sell this story, this disease model to the public. And number two is the drug companies were so happy about this, they understood it was going to increase the market, and they began giving money to the APA to tell this story, to fund its public relations efforts. And they began giving money to academic psychiatrists to serve as their speakers and key opinion leaders. And by the way, in the late 1990s, the New England Journal of Medicine wanted to do a review about the efficacy of antidepressants. And so they looked for experts in mood disorders in the United States at academic centers. And they basically almost couldn't find anybody who wasn't taking money from the pharmaceutical companies. So by the end of the 1990s, basically this capture of academic psychiatry by the pharmaceutical industry was complete. So now we're going to move to the next question. Did this merger of interest, did this financial influence of both guild interests and pharmaceutical interests, did it affect the narrative science that governs psychiatric care? In other words, what were we told? How did it affect the setting of diagnostic boundaries? And how did it affect reporting results from the trials of psychiatric drugs? And what we want to see as we do this is, was the story told to us consistent with what actually is in the research? Or is there a big gap? Okay. So the key thing we are told beginning in the beginning in the 1980s and then going forward is that, as we saw in Nancy Andreasen's book, The Broken Brain, that researchers were saying that they had discovered that, say, depression was due to too little serotonin, schizophrenia to too much dopamine. In other words, they had discovered that chemical imbalances were the causes of mental disorders, and we're going to hear that the new drugs can fix those chemical imbalances, like insulin for diabetes. But now we want to go back, first of all, and see what were the origins of that chemical imbalance hypothesis. And what you find is it arose from an understanding not of what was happening in the brains of people so diagnosed, but it arose from an understanding of how the drugs impacted the brain. What was their mechanism of action? So in the 1960s, it was discovered that antipsychotics, these were the first generation antipsychotics like Thorazine and Haldol, what they did is they blocked dopamine receptors in the brain. In other words, they thwarted dopamine transmission in the brain. And this led researchers to hypothesize, well, if the drugs work and they diminish dopamine activity, then maybe psychotic disorders are due to too much dopamine activity in the brain. In other words, they hypothesized that the cause was the opposite of the mechanism of action. And at the same time, antidepressants, and there were two types in the 1960s, the monoamine oxidase inhibitors and the tricyclics, and both worked, even by different mechanisms, of keeping serotonin in that tiny gap between neurons longer than normal. So we know how neurons work. You have a presynaptic neuron that releases that molecule into that tiny gap between neurons. Then that molecule binds with receptors on the postsynaptic neuron. That's how a message is passed from one neuron to the next. And then in order for this messaging to be crisp, that molecule, that neurotransmitter, has to be removed from the synaptic cleft, and it's either removed by an enzyme and it's carted off this waste, or it goes back into the presynaptic neuron and then is reused. So what they found is that both of these classes of drugs kept serotonin in that synaptic cleft longer than normal, upping serotonergic activity. So researchers hypothesized, well, if that's so, maybe depression is due to too little serotonin. That's the origins of it. That's the hypothesis. Now, what happens in 1980, following the publication of DSM-3, we hear this chemical imbalance story, and we hear it, we're told as if it's been found to be true. So, for example, 1981, you can just read it here. 1988, antidepressants restore the chemical imbalance that scientists have linked to many depressions. That's saying that the hypothesis has been proven to be true. We found that people with depression have low serotonin. And then in 2001, the American Psychiatric Association published some articles in Pharmaceutical, and here's what they told the public. We now know that mental illnesses such as depression or schizophrenia are not moral weaknesses or imagined, but real diseases caused by abnormalities of brain structure and imbalance of chemicals in the brain. So we're told in 2001 that this research has proven that low serotonin is the cause of depression, and that in fact, for example, too much dopamine is the cause of schizophrenia. What's going on here? Okay. And you'll go on, antidepressants restore brain chemistry to normal. And then 2005, the American Psychiatric Association put a press release. A psychiatrist is a specialist specifically trained to diagnose and treat chemical imbalances. They have one of their brochures they put out to the media and also to the public and left in doctors' offices. They said antidepressants may be prescribed to correct chemical imbalances in the levels of chemicals in the brain. And then the National Alliance on the Mental Illness, for example, in 2014, research has shown that imbalance in neurotransmitters like serotonin, dopamine, and norepinephrine can be corrected with antidepressants. So this is a story that is told to the American public. It's a story of an extraordinary advance, that the biological causes of these illnesses have been found. The cause of depression is different than the cause of schizophrenia, and they can fix it. And this is a story of a great advance. It's also a story of why you need to stay on these drugs, okay? And it's also why they should be first-line therapy, because they are curative in essence. They're fixing a known pathology. But that's what we were told. Now we have to go back to the early 1980s, because there is research that's going to be done to see if people with depression, for example, actually have low serotonin, if that's a regular feature of their brains before they go on the drugs. And as early as 1984, the NIMH, doing a study on this, said elevations or decrements in the functioning of serotonergic systems per se are not likely to be associated with depression. They weren't finding that people with depression had low serotonin activity prior to going on the antidepressants. Now, over the next 15, 16 years, there's going to be all sorts of studies done to see if they can identify low serotonin as a problem in depressed patients before they go on the drugs. And their own textbook of psychiatry in 1999 says, this hypothesis was proposed in 1965, and that monoamine, serotonin is a monoamine, is deficient in depression. Then they say, two, this hypothesis was based on observation of how the antidepressants work. They keep serotonin longer, monoamines longer in the synaptic cleft. Next, they say, inferring neurotransmitter pathophysiology from an observed action of a class of medications on neurotransmitter availability is similar to concluding that because aspirin causes gastrointestinal bleeding, headaches are caused by too much blood loss, and the therapeutic action of aspirin in headaches involves blood loss. What they're saying here, this was a rather ridiculous hypothesis in the first place, because there's no reason that the pathology is going to be of a disease or disorder is going to be opposite of the drug that treats symptoms. And now here's the key. Additional experience has not confirmed the monoamine depletion hypothesis. So in 1999, the APA's own textbook is saying, we are not finding that people with depression have low serotonin. Of course, that's not what is being told to the public. And now you can go on, and there's all sorts of comments in the research literature. You can see where they're saying we're just not finding that depression is caused by low serotonin. Alan Fraser was one of the people who spent decades researching this. And what did he say in 2012? I don't think there's any convincing body of data that anybody has ever found that depression is associated to a significant extent with loss of serotonin. In other words, he's saying the hypothesis never panned out. And now the dopamine theory of schizophrenia, it's a bit more complicated, but as early as 1992, Jonathan Kane, a well-known schizophrenia researcher, was saying the simple dopamine hyperactivity theory is no longer credible. And here's Stephen Hyman, former director of the NIMH. He says there is no compelling evidence that a lesion in the dopamine system is a primary cause of schizophrenia. Then Kenneth Kendler, who was one of the world's leading experts on this whole question and the editor of Psychological Medicine, he said this: we have hunted for big, simple neurochemical explanations for psychiatric disorders and have not found them. That was the conclusion from 25 years of research into the chemical imbalance theory of mental disorders. Of course, this is the same year that the APA is saying that psychiatrists are experts in fixing chemical imbalances in the brain. And Ronald Pies, he's a well-known psychiatrist who was editor-in-chief of Psychiatric Times. He says this: in truth, chemical imbalance notion was always a kind of urban legend, never a theory seriously propounded by well-informed psychiatrists. Now, in essence, he's right here, because if you read the research literature, all along there's people saying we're not finding it. It's sort of a not very wise, not very well-reasoned hypothesis in the first place. And by 1999, 1990s, you see it being discredited or abandoned in the research literature. That's what was happening in the research literature. Of course, what is happening in the announcement to the public is a very different thing. And here's the point. In a 2006 survey, 87% of Americans said they now knew that schizophrenia was caused by chemical imbalance, and 80% said they now knew that depression was caused by a chemical imbalance. And so here you have the gulf, the extraordinary gulf between what research showed, which was that the chemical imbalance hypothesis hadn't panned out, and how the society was organized its thinking and use of psychiatric drugs around the belief that research had in fact found that depression was due to too little serotonin, that in fact found that schizophrenia was caused by too much dopamine. And that is part of the problem, the huge problem with the disease model, and how we organized our thinking. We organized our thinking around a marketing claim, not a scientific claim. Now, that's actually only half of the disturbing part of this story. Because as they were investigating, researchers, the chemical imbalance theory, here's what they found. They found that when you went on these drugs, they did induce changes in the brain, and they actually induced the very abnormality hypothesized to cause the problem in the first place. So, for example, this is just a graphic I took from a textbook. This shows a normal passage of dopamine in the brain from a presynaptic neuron, and it's binding with dopamine receptors, okay? Now, once you go on antipsychotics, which block those receptors on the postsynaptic neuron, the brain says, uh-oh, I have a problem. My dopamine function is not functioning well. It has all these feedback loops. And so the brain tries to maintain what's called a homeostatic equilibrium. It goes through adjustments trying to maintain its normal dopamine function. And what does it do? It increases its receptors to compensate for the drug blockade. Well, this extra dopamine receptors was actually hypothesized to be a cause of schizophrenia, cause of an example of dopamine hyperactivity. But what they really found was they didn't find this dopamine, this receptor increase in receptor density before you went on the drug, but you do have it after you went on the drug. Okay. So we were told that psychiatric drugs normalize brain function. What they do is they abnormalize brain function. And this was put forth in a paper by Stephen Hyman when he was director of the NIMH in 1996. And here's what he said in a paper called A Paradigm for Understanding Psychotropic Drug Action. Psychiatric medications create perturbations in neurotransmitter functions. They don't normalize it, they abnormalize it. In response, the brain goes through a series of compensatory adaptations in order to maintain their equilibrium in the face of alterations in the environment. That's that effort to maintain homeostatic equilibrium. Key, the chronic administration of the drugs then cause substantial and long-lasting alterations in neural function. After a few weeks, the person's brain is now functioning in a manner that is both qualitatively as well as quantitatively different from the normal state. So research was showing that rather than fixing a known abnormality, showed that there was no normality before you went on the drugs, and then the drugs actually caused your brain to begin operating in an abnormal manner. So that tells us how much we were led astray by this marketing of this new story. Just real quickly, pharmaceutical companies, of course, also wanted to expand the boundaries, make it easier for people to get diagnosed. And so, for example, when DSM-4 was created in 1994, Lisa Cosgrove looked at how many of the people on the task force had ties to pharmaceutical companies. And she did the same for DSM-5. The task force is the force that governs everything. And you'll see that 57% did in DSM-4, 69% in DSM-5. Now, in addition, the DSM, when they were creating a DSM, they have work panels for the different diagnoses. And you'll see, like in some of them, mood disorders, 100% in DSM-4 had ties to the drug company. And then 100% for schizophrenia. And what's important here is as they're going to be loosening the boundaries, this is what make it easier to make a diagnosis, create more diagnostic categories, and also make it easier to make a diagnosis. They're being paid by drug companies, in essence, to make it easier to make a diagnosis. You'll see that in DSM-4, we get new disorders. We now have almost 300. But more important, the diagnostic criteria for many disorders are loosened. And after 1994, after DSM-4 is published, researchers do a survey and they say, wow, 26% of American adults now suffer from a diagnosable mental disorder each year, and that 13% of youth do. That's based on these categories. It's not based on some sort of survey in Nature about what actually a mental disorder is. It's just saying they qualify for a disorder in DSM-4, which shows you how big the market now has become for psychiatric drugs, that basically 1 in 4 people can be diagnosed with a mental disorder at any time. DSM-5, we get some new disorders, also further expansion of some disorders. And just real quickly, here's how the ADHD market was built. So there was no attention deficit disorder prior in DSM-1 or DSM-2. It's first created as a discrete disorder in 1980. The cardinal symptoms said to be inattention, impulsivity, and hyperactivity. And they say it affects about 3% of children. Now in DSM-4, they say there's 3 subtypes: inattentive only, hyperactive, impulsive only, and those have both. Now you only needed one of those types, made it easier to diagnose, and disorder now said to affect 3 to 5% of all American children. After 1994, Biederman, who was a child psychiatrist at Massachusetts General Hospital, and he'd been a member of the DSM-4 work panel, he begins publishing articles that state 6 to 9% of American school children have ADHD, and the stimulants provide a long-term benefit. DSM-5 further loosens the boundaries for diagnosing ADHD, and by 2016, 12% of school-age youths had been diagnosed with ADHD. And I'm just showing you here's the growth of ADHD in U.S. youth. And of course, this created a big market for stimulants, and pharmaceutical companies were very happy about that. And what's the payoff to Joseph Biederman? He was the lead guy in helping build this market. Over a period of 15 years, he received speakers fees, consulting fees, and research funding from more than 24 pharmaceutical companies, including 3 that made 3 popular ADHD drugs. Just one of these companies paid him $1.6 million during this time. So you see that academic psychiatrists who help build markets, who help convince the public that these are discrete disorders that need drug treatment, they're going to be paid handsomely by the drug companies for creating this. I'm going to get a little bit behind here, although not really too bad. But I just want to show you how this now affects what we're told about the efficacy of drugs. So Xanax is going to be the first drug tested for psychiatric disorder after the publication of DSM-3. And we're going to learn, and panic disorder was created as a separate diagnosis in 1980. Before it had just been part of an anxiety diagnosis. And here's what they reported: that after 4 weeks, the drug provided a statistically significant benefit in terms of reduction of panic attacks each week. And you'll see, although placebo got better, Xanax had a greater reduction of panic attacks. And this is the finding that's going to be reported in, emphasized in research journals and promoted to the prescribing public and to the public. But this was not a 4-week study. This actually had 2 endpoints. The first one was 8 weeks. That was the period of active treatment. And you'll see at the end of 8 weeks, there was no difference, no statistically significant difference in panic attacks between placebo and the Xanax group. And then, because benzodiazepines were known to be addictive, the study had to have a withdrawal phase when people who were either going to be withdrawn from placebo if they're in the placebo group, or they're going to be withdrawn from Xanax if they've been randomized to Xanax. And look what happens to the Xanax patients randomized to Xanax when they were withdrawn. They get much, much worse. They have a rebound, episodes of panic. You'll see they're now worse off than they were at baseline. And I forget the number, but a high percentage were unable to get off, like something like 40%. So the data actually tells you of a drug that's going to lose its effectiveness at 8 weeks, and then it's going to be very tough to get off, and that when you come off, you're going to be having worse panic attacks than you had even in the beginning at baseline, and much, much worse than the placebo group. So you see right away that what's going to happen with this merger with the guild wanting to promote drugs and the pharmaceutical industry wanting to promote drugs, they're going to be very selective in data and findings that are promoted to the public. Now, here's the STAR-D study. It was done in the early 2000s, and it was funded by the National Institute of Mental Health. It was touted as the largest and longest study ever done to evaluate depression treatment. And the reason they did it, they said this: those drug industry trials are conducted in a select group of patients, and they use exclusion criteria that eliminates most people with depression, most real-world patients. So they said, we're going to conduct a study in real-world patients to see how well antidepressants work. It's not going to be placebo-controlled. The way the study is going to be designed is they're going to people with moderate depression, a score of 14 or above on the HAM-D are going to be treated with an antidepressant. And if they don't get better after 12 weeks, then they'll be treated with a different antidepressant, maybe psychotherapy. And if they don't get better after the second try, they can have a third try with a different combination of drugs. And they'll be given 4 tries to have a moment when they remit, when all of a sudden their depression is gone. And then when they remit, they'll be put into a year-long follow-up trial to see if they stay well. Now, in 2006, the STAR-D investigators announced the good news. Over the course of all 4 levels, after 4 treatments, almost 70% of those who didn't withdraw from the study became symptom-free. They just got completely better. And this was the message that was promoted to the public, to doctors, to prescribers. And the message became this: if the first drug doesn't work, try a second. If that doesn't, try a third. If that doesn't, try a fourth or a combination. And eventually, 70% of people will just get fully better. And this became the governing information, the governing evidence base for prescribers for the next 16, 17 years. And newspapers regularly touted this finding as evidence of the efficacy of antidepressants. And you'll see this, 2022, by the end of the study, half of the participants had significantly improved after using either the first or second medication, and nearly 70% had become symptom-free by the 4th antidepressant. Now, actually, as early as 2010, there was a psychologist named Ed Piggott who published a paper showing that there had been various protocol reviews to inflate those results, and that the actual results were closer to this. There were 4,041 who enrolled. Only 1,518 remitted. That's 38%. Of the 1,518 that were then went into the year-long trial to see if they could stay well, and doctors could change their prescriptions, they could change the doses, only 108 were still well at the end of 1 year. The remaining 3,933 had either never remitted, relapsed, or dropped out. That's a stay well rate at the end of 1 year of 3%. Yet the public is being told 70%. Now, this past August, Piggott and his their colleagues, they got access to the patient level data, and they said the actual remission rate was only 35%, not 38%. And they documented very closely all the ways that the researchers violated the protocol, including counting people who weren't even depressed at the beginning of the study, to dramatically inflate their outcomes. Now, it was funded by the NIMH. However, the people who did this trial did work for numerous pharmaceutical companies. August Rush was the lead investigator. He had 17 ties to the makers of psychiatric drugs. Another big one was M. Trivedi. He had 21. Another one was Mauricio Fava. He had 39 ties. So even though it's not funded by the drug companies, these people were being paid, in essence, to maintain societal belief in antidepressants as a first-line therapy. And of course, their guild wanted them to do this as well. And so what do we see happened? They in essence told us a false result. They doubled the actual remission rate, and they hid the fact that only 108, 3% were well at the end of 1 year. There was a table that published that, but they never discussed it. Now, real quickly, we have had other NIMH studies designed to see how do these drug treatments work in real-world patients and over longer periods of time. The long study was of ADHD was called the MTA study of ADHD. When they mounted this, they said this will be the first well-controlled study of stimulants for ADHD, and it should guide our care of use of stimulants in children. And here's the result that was promoted to the public. At the end of 14 months, youth treated with a stimulant had a greater reduction in ADHD symptoms than those treated with behavioral therapy. They also performed slightly better on reading tests. The researchers concluded since ADHD is now regarded by most experts as a chronic disorder, ongoing treatment often seems necessary. What your public wasn't told this, but if you read the follow-up players closely, you find that at the end of 3 years, medication use was a significant marker, not of benefit, but of deterioration. Medicated children were also slightly smaller and had higher delinquency scores. At the end of 6 years, medication use was associated with worse hyperactivity, impulsivity, and oppositional defiant disorder symptoms, and with greater overall functional impairment. I guarantee you, you did not see that. You weren't told this by if you had a child who was seen as having ADHD, you were not told about these 3 years and 6 year results. They weren't promoted by psychiatry to the public. They weren't promoted to prescribers. They weren't in the textbooks. You had to read, and they weren't even in the abstracts. You had to read the 3 year report and the 6 year report real closely to see that there was this worse outcomes for the medicated children. And once again, I just looked at the investigators on this study and the ties they had to pharmaceutical companies, and you'll see they had many ties, including being on speakers bureaus and serving as consultants. So, of course, that gives them a reason, a motivation to protect the use of stimulants as a first-line treatment for ADHD. One more such study. This is the TAD study, Treatment of Adolescent Depression study, that was mounted when their black box warning was put on antidepressants, saying they increased the suicide risk for those who were young. And what they reported in this study was that that wasn't true. There was no excess suicidal risk. So the way the study was done, people either randomized to placebo or CBT or Prozac or Prozac plus CBT. And if you look at the total at the end of 9 months, suicidal ideation was 10 in the non-drug group, 9 in the suicidal attempts in the non-drug group, fluoxetine, 16 suicidal ideation, 9 in the suicidal attempts. And they concluded there is no evidence of medication-induced behavioral activization as a precursor to a suicidal event. This conclusion was what gave the green light for child psychiatrists and others to begin prescribing antidepressants to youth again, because they said this NIMH study had, in fact, not found they increased the risk of suicide. But then, if you read the study closely, here's what you find, and this is what I did. Those randomized to placebo after 12 weeks, many were then put on the drug. Not all of them, but some of them. Same with the CBT group. After 12 weeks, some were put on drug. So there was a table in the publication that showed whether the person was on drug when they suffered suicidal ideation or suicidal attempts. And here's what you find. During the first 12 weeks, when the non-drug group, in fact, was only on placebo or CBT, there were 7 had suicidal ideation and 1 suicide attempts. Those who stayed off for the next 24 weeks, they had no more suicidal ideation, no more suicidal attempts. So there was a total of 7 suicidal ideations and 1 suicidal attempt in the non-drug group. But now you have randomized to placebo, but switched to fluoxetine at 12 weeks. And what do you see? You see 3 suicidal ideation and 6 suicidal attempts in that group. Then you have randomized to CBT, but then switched to fluoxetine at 12 to 36 weeks. You see also suicidal attempts. So the bottom line was this. The total people who had suicidal ideation, 7 were on not drugs, 19 were on drugs, but most important, suicidal attempts. There was only 1 in someone not exposed to the drugs, antidepressants, 17 among those who exposed to drugs. So they hid the fact that nearly all suicide attempts occurred in drug people taking fluoxetine, and instead said, by hiding this fact that what they did is randomized to placebo, switched to drug. Those in their own study, they assigned that suicidal attempt to placebo. That's how the sort of misdirection happened. So what we see here is, again, a betrayal of the public. The study actually showed it was the kids on fluoxetine that had the suicidal attempts, and yet they hid that and instead said there was no difference. This led to suicide. This led to increased use of antidepressants. And we have now had almost 20 years of rising suicide rates among our youth since prescribing of antidepressants became common to youth. and seen it's not problematic. And again, once again, basically the investigators had ties to Eli Lilly, which is the maker of fluoxetine, and they received honorariums, re-supports, consulting contracts, and served on the speakers bureaus. Okay, there was another NIMH study before they started the study, and they said, well, we don't know what the course of untreated depression is. So we're going to have to figure out, does treated depression, meaning treated with antidepressants, or actually probably psychotherapy, do they do better than untreated? And here's what they found at the end of 6 years, that 32% of those treated had a cessation of role function. In other words, they stopped working or whatever their role was in life, versus 10% of those untreated and became incapacitated on disability. It was 7 times higher for those who were treated. So here you see, once again, you never hear about this, but you see the natural course of depression in this study has a milder long-term course than those who are treated. This is the best long-term study that's been done of schizophrenia patients, so I'll get more into it in the second half of this presentation, but you'll see that the recovery rate for those off antipsychotics who took themselves off beginning at 2 years was 8 times higher than those on the drugs. Have you heard about that? Well, if you've read Anatomy of an Epidemic, or if you've gone to Mad in America, you have. But this finding was not promoted to the public. So that's the part one of this talk. And the part one is basically this. In 1980, the American Psychiatric Association, for guild reasons, decided to rebrand itself. They wanted to rebrand themselves as doctors in white coats who treated real illnesses of the brain. We then heard, the public was told, that they discovered that chemical imbalances were the cause of major disorders, that new drugs fixed those chemical imbalances like insulin for diabetes, all which is a story of great progress. And this led to a great expansion of the psychiatric enterprise. In 1987, we were spending United States, about $800 million in psychiatric drugs. In 2007, we were spending $40 billion in psychiatric drugs in the United States, a 50-fold increase in market size. And as that story was told, we weren't told about what research was telling us about the chemical imbalance story, that it hadn't panned out. We weren't told about how the drugs abnormalized brain function, and we weren't told about poor long-term outcomes in NIMH-funded studies. So we have this extraordinary gap between what we're told and what the research shows. Now, real quickly, and I'm running a little bit behind, so I'm going to go quickly through this if I can. I just want to show that there's a history of science regarding the long-term effects of antipsychotics and of antidepressants. And I'm going to focus mostly on antipsychotics, and here's why. The conventional wisdom in the conventional story goes like this. Antipsychotics arrived in asylum medicine in 1955, and this kicked off a psychopharmacological revolution, a great advance in care. And of course, we now are told that people with schizophrenia and psychotic episodes have to be on antipsychotics, that when they come off, they relapse all the time. And this is seen and that it was the antipsychotics that made people to live fairly normal lives in the community. We've heard that at various times. So this whole psychopharmacology revolution, at the heart of it is a story of how drugs were introduced that helped tame psychosis, that helped dramatically improve the long-term course of psychosis. So what I want to do is see does the data support that story? And what we're going to do is we're going to look at some studies that were done in the 1960s and 1970s on the first generation antipsychotics. And then we're going to look at the second generation. The second generation are like Risperdal, Zyprexa, Seroquel, et cetera. And we're going to see if all this research comes together like pieces of a puzzle to tell a story about the long-term effects of antipsychotics. So one of the first studies that was done at Boston Psychopathic Hospital. They had a 5-year outcome data on a 1947 cohort of first episode psychotic patients and that were discharged. And then the relapse rates within 5 years of discharge was 55%. They had a similar group of first episode patients treated in 1967 with drugs, and their relapse rate was higher in the 5 years after their hospitalization. And here's the big difference. In the 1947 cohort, 76% were successfully living in the community at the end of 5 years, meaning they weren't on disability. '67 cohort were much more socially dependent on welfare and needing other support than the 1947 cohort. So what do they say? The researchers. Rather unexpectedly, these data suggest that psychotropic drugs may not be indispensable. Their extended use in aftercare may prolong the social dependency of many discharged patients. There were other studies of this in the 60s that raised questions about the use of antipsychotics. So in the 1970s, the NIMH funded 3 studies to look at the longer-term impact of antipsychotics. The first was done by Maurice Rappaport at a hospital in California. It was randomized. You had, I'm pretty sure this was first episode patients. They come into the hospital. They're either randomized to placebo in the hospital or to antipsychotic in the hospital. Then they're discharged and they're followed for 3 years. And during this 3-year period, they're free to either go off their medications or start taking medication. So what you have here is there were 41 people randomized to placebo in the trial. Placebo off means 24 were treated with placebo in the hospital and they remained off during the 3 years. Placebo on means they were treated with placebo in the hospital and then went on antipsychotics in the 3 years. Antipsychotics off means treated with antipsychotics in the in the hospital and then they went off. Now look at the outcomes. The best group by far is the group that were never exposed to antipsychotic. Their severity of illness was the least at the end of 3 years, and the rehospitalization rate was 8%. What this is showing is that about 2/3 of first episode patients, if not put on antipsychotics, can recover over time and do fairly well and not go down a chronic course. And you'll see you can go on antipsychotic off, much worse, but the worst is, in fact, antipsychotic and then continual use. And they had this is the recommended form of care. They had the greatest severity of illness and the greatest rehospitalization rates. So what did Rappaport suggest? And you can just read this real quickly. Just read it yourself. His conclusion is basically we need to rethink this if we're looking at long-term clinical improvement and functioning. As you'll see, the unmedicated while in hospital group showed greater long-term improvement, less pathology, fewer hospitalizations, etc. Now, the next was a famous study done by Lauren Mosher called the Soteria Project. And in this project, newly diagnosed patients were randomized either to treatment as usual in the hospital or to a residential home, Soteria staffed by ordinary people. The home actually was, this experiment ran for 10 years. It was directed by, the director was Voice Hendricks, the cousin of Jimi Hendrix. And those randomized to Soteria were not immediately put on antipsychotics, and initiation of antipsychotics would begin only if patients failed to improve or deteriorated. As I said, it ran 12 years. Here were the results. At the end of 6 weeks, the group that was treated initially in Soteria, where antipsychotics weren't immediately used, they had the same improvement in psychopathology at the end of 6 weeks of those treated regularly with drugs in the hospital. At the end of 2 years, this form of care, which really made use of selective use of antipsychotics, had better outcomes, lower psychopathology scores, fewer readmissions, better global adjustment. And here's the kicker. In terms of antipsychotic use, 42% never been exposed to the drugs, 39% used them temporarily, and 19% used them regularly. So what you see from this is better outcomes with the selective use of the drugs. And again, where they said minimal use actually seems to be advantageous. Lauren Mosher, by the way, was the head of schizophrenia studies at the NIMH when he conducted this study. We think the balance of risks and benefits associated with the common practice of medicating nearly all early episodes of psychosis should be re-examined. Second study. The third study was done at the NIMH's own in-house facility. It compared 27 schizophrenia patients treated with psychotherapy and no antipsychotics to 22 patients treated with both psychotherapy and antipsychotics. You see those treated without drugs were discharged sooner. They had a lower relapse rate, and most important, they suffered less from depression, blunted emotions, and retarded movements. So all 3 studies done in the 1970s raised questions about the long-term impact of antipsychotics, including whether they were making them more chronic. And here's what William Carpenter wrote in 1977. He says there's no question that once patients are placed on medication, they are less vulnerable to relapse if maintained on the drugs. And that's the information from studies where you take people who've responded well to antipsychotics. One group is randomized and taken off the drug. The other group is by randomization is continued on the drug, and those taken off the drugs usually abruptly have higher relapse rates. But watch this question. What if these patients had never been treated with drugs to begin with? We raise the possibility that that antipsychotic medication may make some schizophrenic patients more vulnerable to future relapse than would be the case in the normal course of the illness. Thus, as with tardive dyskinesia, we may have a situation where neuroleptics increase the risk for subsequent illness, but must be maintained to prevent this risk from becoming manifest. So they're saying here, in the 1970s, maybe these drugs are making people more biologically vulnerable to psychosis and therefore have a worse long-term outcome. Then two researchers from McGill University put together an explanation for what was happening. They said, once again, there's normal functioning. The drugs block the receptor. The brains increase the receptors. And then they said, once this happens, there's a dopamine supersensitivity that has been induced in the brain. Okay. Once there's this adaptation to the drug. And they said, neuroleptics can produce a dopamine supersensitivity that leads to both dyskinetic and psychotic symptoms. The drugs are causing a change that increases the risk of psychosis. An implication is that the tendency towards psychotic relapse in a patient who has developed such a supersensitivity is determined by more than just the normal course of the illness. So that's where we were at the end of the 1970s and beginning of 1980s. There was research showing that over the long term, it seemed that antipsychotics were increasing the risk of relapse and impairing functional recovery. And there was a biological explanation for why antipsychotics had this effect, okay? Now, in 1980, we get DSM-3. Later in the 1990s, we get the second generation of antipsychotics. And what we want to see now is research that's been done since then, does it agree with that worry that arose in the 1960s and 70s? In other words, does it provide supporting evidence, or does it contradict it and say we don't have to worry about this drug-induced dopamine supersensitivity? And what you find, well, now we'll just real quickly go through every type of research I could find. First, there were cross-cultural studies done by the World Health Organization in the 1970s and 1980s. One was 2 years in length, one was 5 years in length. And what they did is they compared outcomes in 3 developing countries, India, Nigeria, and Colombia, with outcomes in the US and 6 other developed countries. Everybody was diagnosed by Western doctors, so there was a standardization of diagnosis. And what did they report each time? That those people diagnosed with schizophrenia in the developing countries had a considerably better course and outcome than in the US and 6 other developed countries. They even wrote that being in a developed country was a strong predictor of not attaining a complete remission. And in the poor countries, they had exceptionally good outcomes. Now, after the first such finding, the World Health Organization investigators hypothesized maybe the reason for the better outcomes in the developing countries is the patients are more medication compliant. They don't stop taking the drugs like many people do in the developed countries. So they looked at medication usage in the second study, and here's what they found. Only 16% of patients in the developing countries were regularly maintained on antipsychotics. It means that drugs were used acutely but not chronically, where, of course, maintenance therapy is the standard of care in the rich countries. So we're seeing better outcomes where the drugs are only used short periods of time for most people, not long-term. And then when they went back 15 to 20 years later, they found that there was a significant outcome differential between patients in the developing countries versus those in the rich countries. And look in the developing countries where drugs weren't used, antipsychotics weren't used on a continual basis, 53% were never psychotic anymore, and 73% were employed. So at least in this cross-cultural study, it supports this worry that antipsychotics are worsening long-term outcomes. Now, this is Martin Harrell's long-term study of psychotic patients. I gave you the one graphic from that study earlier. He enrolls 200 patients. He's a psychologist from Illinois. The study was done also with a psychiatrist named Thomas Job. They enrolled 200 patients that came to either one of two hospitals, a private hospital in Chicago area or a public. And at 15 years, they still had 145 patients in their study. Here's how the study, and you'll see it's the cohort. They get admitted into a hospital. They get treated with antipsychotics, and you'll see 64 of the 145 were diagnosed with schizophrenia, 81 with milder psychotic disorders. And here's what's important: it's a young group, so we're going to follow them. We're going to follow them from an early point in the course of their disorder. This is the first hospitalization, and the way the study works is this: they're all treated with antipsychotics in the hospital, then they're discharged. And now they're free to do what people do after they're discharged. They can either continue taking their medications or they can go off. And what Martin Harrow and Thomas Job are going to do, they're going to follow up at 2 years, 4.5 years, 7.5 years, 10 and 15, and eventually 20. And just look at how well are they doing. Are they taking antipsychotics? Are they psychotic? How anxious are they? Are they working? That sort of thing. So here's what you see at the end of 2 years. At the end of 2 years, roughly 25 of the 64 schizophrenia patients were off the antipsychotics. Look what happens with anxiety. Those on antipsychotics remain very anxious, whereas it diminishes those who, as they get off and they recover from their psychosis. So much less anxious for those that got off, better cognitive function for those who got off. This is really key. Now, at one point, what they do is they compare those who never used any antipsychotic during the follow-up starting in year 2 to those who were medication compliant for up through 20 years. And what do you see? You see that those who stopped using antipsychotics at the second year and were able to get better and get stable remained very stable. They had low relapse rates. You see this in the bottom one. But look what happens to the medication compliant people who theoretically the medication is being used to stop the psychotic symptoms. But in fact, about 2/3 at every follow-up or even higher would still have psychotic activity. Work history, much, much better for those off antipsychotics. And look at this. Nearly 90% by years 5 were working. Those were off antipsychotics. And by the way, those off antipsychotics had dropped out of the psychiatric system. Several had gone back to school. One became a lawyer. One became a teacher. And what Harrow and Job discovered, of course, is those that recovered in this way, they didn't tell people that they once had a diagnosis of schizophrenia and once had been in a mental hospital. And so what Harrow and Job says, we lose track of these people. We don't see these people. The only people that the psychiatrists see are those who go off their drugs and do poorly. This is the recovery rate, 8 times higher for those off medication. You'll also notice he divided his outcomes into recovered, fair, and uniformly poor. On the group that used antipsychotics for 15 years, 5% recovery rate, 40%, 6% fair, 49% uniformly poor. But you'll see only 16% uniformly poor for those off antipsychotics. So it's like the spectrum of outcomes had shifted. Here's what he concluded. Martin Harrow, 2008, I conclude that patients with schizophrenia not on antipsychotic medication for a long period of time have significantly better global function than those on antipsychotics. Now, I wrote about this in the book Anatomy of an Epidemic. Mad in America has made a big deal of it, but I guarantee you this conclusion, this research, it's just never been reported by the mainstream media. It's not in the textbooks, and it doesn't inform protocols. And the reason is because it goes against the conventional wisdom and conventional practices. Real quickly, you see in the milder group, it was the off antipsychotic group that did better. And now here's a really interesting thing. This shows you have 4 groups: schizophrenia on antipsychotics, milder disorders on antipsychotics, schizophrenia off, mild disorders off. Now, you would think that schizophrenia off would have a worse outcome than milder disorders on antipsychotics because they had a better baseline prognosis. But here's what do you see. The worst is schizophrenia on antipsychotics. Next worst is milder disorders on antipsychotics. Then it's schizophrenia off, milder disorders off. So how do you explain that milder disorders on antipsychotics has a worse outcome than schizophrenia off antipsychotics? The only explanation I can come up with is that the antipsychotics are worsening long-term outcomes. And again, this is just showing the difference. Those who stayed on antipsychotics, more psychotic, more anxious, worse cognitive function, lower recovery rates, much more likely to have a uniformity outcome, had worse global outcomes. He then raises the question, is very long treatment with antipsychotic medications undesirable? I think I'm going to skip the rest so I can get through this. There was a randomized study by Lex Wondrink in the Netherlands, and basically what he found was this. Those who were randomized to a drug reduction discontinuation arm, this is first episode patients, had a more than twice a recovery rate than those maintained on the drugs. And so he concluded same thing, we needed to rethink this. There was a first episode study in Australia, and they had medication usage for 209 patients at the end of 75 years. You'll see the full functional recovery, 56% off that weren't using the drugs, only 14% that were. You see the same thing in a UK study, recovered at 10 years. It's those off having much higher recovery rates. There was Denmark did a 10-year study of 496 first episode patients. At time of recruitment, patients have been on antipsychotics less than 12 weeks. At 10 years, there were 303 patients still in the study. There were 120 who were non-compliant and had stopped taking antipsychotics. And there was no difference at baseline between those who were non-compliant and had stopped taking antipsychotics and those who were compliant and were taking the antipsychotics. And here's the difference. In remission, much more likely those off antipsychotics, and much more likely to be employed those off antipsychotics. So what you see from all these different studies over and over again, there are higher recovery rates, there's higher functioning over the long term for the group that can get off antipsychotics. Then we had MRI technology that came into effect in the 1990s, excuse me. Nancy Andreasen hypothesized that maybe schizophrenia is a progressive neurodevelopmental disorder characterized by progressive reduction in frontal white matter volume. She did a study of 500 first episode patients, and that's what she found. There was a progressive reduction in the frontal white matter volume. Then she and her colleagues reported that as this brain shrinkage happens, it's associated with a worsening of negative symptoms, increased functional impairment, and after 5 years, cognitive decline. She is at this point, remember, she's the editor-in-chief of Psychiatric Times, American Journal of Psychiatry. She is saying this is a disease process, and unfortunately, the drugs don't stop this brain shrinkage, okay? And this is why you get these poor long-term outcomes. However, a study in macaque monkeys found that, in fact, the drugs shrunk their brains, okay? And it was dose related. So all this, and these macaque monkeys obviously didn't have the disease of schizophrenia. So this raised the point that maybe it's the drug causing the shrinkage. So Andreasen goes back to her own research, and she finds that, in fact, the shrinkage is drug related. Use of the old drugs, the atypical drugs, and clozapine were all associated with smaller brain tissue volumes, with decreases in both white and gray matter. The severity of illness and substance abuse had minimal or no effect on brain volumes. In other words, it's not a disease process, this brain shrinkage. It's a drug-induced problem. And you'll see a review of 43 brain imaging studies confirms that antipsychotics shrink the brain. So think about what we have in this data. We have a story done by the leading editor of the American, we have research done by the editor of the American Journal of Psychiatry that says people treated with antipsychotics over time, because this causes a shrinkage of the brain. And as that happens, you see worsening of outcomes, negative symptoms, increased functional impairment, and after 5 years, cognitive decline. That is a story, a neat sort of summing up of an iatrogenic process of how antipsychotics worsen long-term outcomes. You have an agent that causes a known change, and that known change is associated with is then associated over time with worse outcomes. And guess what's happened since 1996? Recovery rates, in fact, have worsened in the antipsychotic era. They're now worse than they were before 1941. And just so you know that this isn't just me presenting data, as this data has become known, you are getting some people saying, we got to rethink the use of these drugs. And this is the editor of the British Journal of Psychiatry. You can read it. And he concludes, we have to reappraise the assumption that they should be a first line of treatment. There is an increasing body of evidence that the adverse effects of antipsychotic treatment are, to put it simply, not worth the candle. Now, I'm going to skip this part, but you'll see that there's the same story with the use of antidepressants. You'll see that it used to be seen as an episodic disorder. Most people, you could expect the depression to lift, especially at the end of 1 year. You'll see even in 1969, they said insurance can be given to a patient and his family that subsequent episodes of illness after a first mania or first depression will not tend towards a more chronic course. Then, though, you begin to see clinicians saying once they're using antidepressants, boy, it seems like my patients are maybe they're getting better faster, but they're relapsing more frequently. You're seeing one psychiatrist says they're inducing a change to a more chronic course. This Dutch psychiatrist tests it, and he does find that the use of antidepressants is associated with an increase in episodes and shorter time between episodes of depression. Now, in 1985, the NIMH convenes a panel, and the panel says, oh, we used to think it was episodic, but now we're seeing that it runs a chronic course. But they're not saying the chronic course is caused by the antidepressants. They're just saying, oh, we have discovered the true course of depression. But what they're really discovering is the course of depression treated with antidepressants. Then we had a couple studies of remission rates in real-world patients treated with antidepressants. This is the STAR-D trial. Look at this. Only about 35% ever admitted, even for a short time, but very low stay-well rates. And then at the same time, so these are the outcomes for treated depressed patients. They conducted a small study of what is the 1-year recovery rate of unmedicated depression, and you'll see that it was 85%. So here we have a documented stay-well rate of 3% with drugs, 85% without. And this is a study by Minnesota over a 4-year period. How many of their patients with a diagnosis of depression, and these are outpatients, are getting better each year. And you'll see that the number of patients that go into remission is very low. That's the blue, very low response rates, and most are remaining chronically ill. So here's the key. What are researchers saying, like Giovanni Fava? Beginning in the 1990s, he's a psychiatrist from Italy. Antidepressant drugs in depression might be beneficial in the short term, but worsen the progression of the disease in the long term by increasing the biochemical vulnerability to depression. They may propel the illness to a more malignant and treatment unresponsive course. And what you see, there's been a lot of studies that are saying that indeed that's what we're seeing. This was a screening for depression that found that those who were diagnosed and treated with antidepressants had a worse outcome than those diagnosed and not treated. Another study found that when Zoloft was added to exercise, that led to a greater persistence of depression than exercise alone. There was a long-term study published in 2017, and what did they say? Symptoms were more sharply elevated 9 years following treatment, including medication, than treatment without medication. This pattern suggests possible long-term iatrogenic effects of antidepressants. For example, antidepressant medications may recruit processes that oppose and eventually overwhelm short-term benefits, resulting in loss of efficacy, resistance to retreatment, paradoxical effects, and withdrawal syndromes. Giovanni Fon says, we may propel the illness to a malignant and treatment unresponsive course. And here's the really sad part of this. When drug treatment ends, these processes may be unopposed and yield withdrawal symptoms and increased vulnerability to relapse. Such processes that make you more vulnerable to depression may not be reversible. And so here's a major mood disorder scholar saying it looks like the drugs can induce something called tardive dysphoria, a late onset in dysphoria. You can read this. So you get treatment-resistant depression, people becoming chronically ill. This is what's in the research literature, but of course, none of this is ever communicated to the public. And I'll just show you what's happened in this disease era. The number of adults receiving a disability payment due to mental illness, you see it's gone up from 1.2 million to nearly 5 million by 2009. I also I was asked by a work group in the UK Parliament to look at the use of antidepressants and government disability due to mood disorders. You see number of government disability due to mood disorders goes up as more antidepressants are used. This happens in the United Kingdom. This happens in Australia, Denmark, Iceland, Sweden, New Zealand. And here's the other thing. We began medicating kids in 1988. At 1988, there were about 16,000 kids on government disability due to mental illness. By the time of 2011, we had nearly 800,000 kids receiving a disability payment. I know I went real fast on that. But what you see in this review of long-term outcomes, in the research literature, you see study after study that is saying of various types that antipsychotics seem to be worsening long-term outcomes, increasing the risk of relapse, causing people to become more biologically vulnerable to psychosis, impairing functioning, that sort of thing. And we see something similar with antidepressants. It changes in the antidepressant era from an episodic to a chronic disorder. People wonder why this might be, and they point to how the drugs cause biological changes in the brain, the opposite of what it is originally intended by the drug. And they say that once this change happens in the brain, where what happens if you go on an SSRI, which ups serotonergic activity, your brain decreases its own serotonergic activity. And even if you come off, it's not sure that it's always going to renormalize. So you might have this sort of permanent tardive dysphoria set in. Now just look at these calls for change at the top. This is from Danius Purse, UN Special Rapporteur on the Right to Health. There is now unequivocal evidence of the failures of a system that relies too heavily on the biomedical model of mental health services, including the frontline and excessive use of psychotropic medicines, and yet though these models persist. This pattern occurs in countries across the national income spectrum. It represents a failure to integrate evidence and the voices of those most affected into policy, and a failure to respect, protect, and fulfill the right to health. And this is from the World Health Organization in 2021. What do they say? A fundamental shift within the mental health field is required in order to end this current situation. In the mental health services context, this means a move towards more balanced, person-centered, holistic, and recovery-oriented practices that consider people in the context of their whole lives, respecting their will and preferences in treatment, implementing alternatives to coercion, and promoting people's right to participation in community inclusion. So we've gone about 90 minutes, almost 90 minutes, and we'll do a few minutes on what's next. This, in some ways, is a story of a tragedy, of course. It's a story of lives that have been harmed, lives that have been impaired, lives that have been lost. And this has happened while we were told a false story about drugs that fix chemical imbalances in the brain. That's a real betrayal of the public. The other betrayal is, as they got these bad outcomes in the long-term studies, whether it be of depression with antidepressants, antidepressants in kids and suicide, stimulants in kids, antipsychotics, and people diagnosed with schizophrenia over and over and over again, we see in those studies where the people who get off medication, on the whole, have better outcomes than those who stay on the medications. All of which calls for a rethinking of the use of the drugs. And yet that information is never presented to the public because, of course, if it were, it would threaten this whole industry of prescribing psychiatric drugs, and in essence, what American psychiatry does and psychiatry does around the world, which is prescribe these drugs. So the public this information has been kept from the public in order to keep this other narrative, this disease model narrative alive. So what's next? Here's the good news. is that what you see in all these studies is so often psychiatric difficulty can be an episodic problem, a time-limited problem, and that people are responsive to their environments. And so if we change the environment, often we can increase that sort of natural capacity to recover. So what's a new narrative for mental health? It begins with this. Rather than trying to say we know this or that, we should start with humility. The human mind is a mystery. It is a very complex, sophisticated place. And what we all know is that growing up is difficult. We know that we are subject to strong emotions, jealousy, worry. We can be, sort of up and down emotional changes. So this idea that we're supposed to be emotionally stable creatures, it's just not true. That's not what we see through history, through books of philosophy, what we see in our films, our novels, what we see in Shakespeare plays. Human beings are very sort of emotional. They have emotional outbursts, and they have good times, bad times. This is part of what it means to be human. And most important is environment matters. We are built to be responsive to our environment. And what you really look when you see psychiatric difficulties, you see there's a lot of pathways, physical illnesses, cardiovascular problems, syphilis leads to it, Parkinson's disease can cause psychiatric problems. Environmental toxins can, for example, lead was known to cause a lot of problems. Physical illnesses like pernicious anemia, they can cause all sorts of psychotic symptoms. Poverty can, trauma can, difficulties in the family can, loss can, social isolation. These are all environmental things too. Lack of meaning in life, social inequality, use of illicit drugs, prescribed medications, et cetera, et cetera. In other words, there isn't just some singular cause in the brain with molecules that lead to these problems. There's a lot of different pathways that lead to anxiety, depression, worry, compulsions, psychosis, lack of sleep, etc. So think about this new narrative. We have humility, the mind's a mystery. 2, there's all sorts of pathways to difficulties. And frankly, that difficulties are part of life when we're growing up and continue. And that we humans are responsive to our environment. And if you want to look at the social determinants of health, you're going to want to improve the environments. I just want this one quote. Back in 1975, Harry Solomon Sanborn Bachman said this: the majority of mental illnesses, especially the most severe, are largely self-limiting in nature if the patient is not subjected to a demeaning experience or loss of rights and liberties. They can add here, I think, are not exposed to chronic use of medications. But this is what we can grab on to be hopeful. Most psychiatric problems, including psychosis, are depression, anxiety, behaviors that get labeled as ADHD. They're self-limiting in nature. You can have a time of difficulty unless we do something to turn them into chronic conditions. Now, if we go and search through the research literature and find either previous models of care that sort of eschewed drugs and looked at environment as ways of helping people, and also do that in previous times, in current times, over and over again, you find relatively good outcomes, even with, quote, the most severely ill. In the first moral therapy was done. It was invented by the Quakers in the late 1700s, early 1800s. They began developing small asylums in the countryside. And here was their thought: we don't know what causes psychosis or insanity, they would say, but we do know, they are brethren, and we also know they're creatures of God, and as creatures of God, they have a God-given capacity to recover, often have a God-given capacity. So, and what our job is to provide help facilitate that natural capacity to recover. And so they built the first asylum in York, England. The Quakers in New York opened such asylums in the United States in the 1800s. And the idea was good food, exercise, People dressed normally. They would give them things to do, or they would not only exercise, they would garden, they would go on walks, they would have their own newspapers, they would have dances. And what you see with moral therapy, and then I'll go through these others real quickly, is that for first episode patients, a majority would recover within 12 years. And these are people who are severely ill and would not relapse into illness. And even sometimes chronic patients got better with this form of care. Now, Worcester Asylum in Boston opened in the 1830s as a public hospital. And they looked at discharged patients. A long-term study was done of patients discharged over a 13-year period. And what did they find? Treated with this form of environmental care, 58% remained well throughout their lives, 7% relapsed, but subsequently recovered. In other words, 2/3 they got discharged and were able to live in the community, and that's without any, disability support services. But about a third did become chronically ill or died while still mentally ill. Okay, but 2/3 got better. Basically the same things at Pennsylvania Hospital for a 40-year patient. 45% were discharged as cured, 25 as improved. And now what do we see in the decade before the arrival of antipsychotics in asylum medicine in 1955? You see something very similar. At Warren Hospital in Pennsylvania, 62% admitted for at least 4 years were discharged within 12 months. Delaware State Hospital, 85% were discharged within 5 years. Stay well rates, around 70%. Again, over and over again, if we look at first episode patients who aren't put on, antipsychotics, this was before, would get discharged and be functioning okay 5 years after their initial hospitalization. I just real quickly, when they did do a study in California about discharge rates for first episode patients after the introduction of thorazine, actually discharge rates were higher for those treated without neuroleptics. And I just did this table of outcomes in different countries where people are diagnosed as insane, schizophrenic, or psychotic, and this is outcomes from the pre-antipsychotic era. York Retreat, 70%, Worcester Asylum, 65%, Pennsylvania, 45 to 70, 73%, 70, 76, 63, 88%. So this belies the idea that no one got well from a psychotic episode before antipsychotics arose. And remember, the Psychiatry project showed the same thing, that if they didn't immediately medicate people, people got at least close to like 70 to 75% got better and were able to live without antipsychotics over the long term. Now, there is something called open dialogue therapy that was practiced in Finland, was developed in the early 1990s. Their conception of psychosis was this: it doesn't arise within the head of the individual, but in the in-between spaces of that individual and their social environments. And so what they think is that you have to use dialogical therapies to repair those in-between spaces. And with their first episode patients, and this was a type of therapy that ran from around 1991 to 2015, they would not put them on antipsychotics right away because they wanted to see who could recover without going on the drugs. If someone wasn't getting better after a period of time, they would put them on an antipsychotic, a low dose. And then they would see after 6 months of those who had exposed to antipsychotic who could come off the drug. So what are their 5-year outcomes? 67% never used antipsychotics, 13% used them for a period of time, 20% continue use. It's a select, a selective use of antipsychotics is the model here, but they're putting their time and effort into repairing those in-between spaces, repairing relationships, helping people who are psychotic get over their fears and be with other people, to start have dreams again, think about what jobs they might have. Psychotic symptoms with this form of care, 79% were asymptomatic at the end of 5 years, and look at their functional outcomes. Only 20% on disability. So this was pioneered by they treated all patients like this. And basically they found once again that with the selective use and intense dialogical environmental care, which was meant to get people back into work, about 80% would have good outcomes at the end of 5 years, and only about 20% would become chronically ill and in need of the drugs all the time. This is a hospital in Norway, in Tromsø, Norway. There was a program there that was initiated by the Ministry of Health that said, and they looked at this very data that I presented today. Actually, I was invited to Norway multiple times to present on this data about the long-term course of antipsychotics, psychosis with antipsychotics. And the health minister said then, we need to give patients, including psychotic patients who come to the hospital, who don't want medication, the chance to be retreated in a hospital setting without medication. I went there. This is the group of peers that got together and lobbied the health minister to require every hospital system to start providing medication-free treatment to patients who wanted it. And here's what they say. One of the people in Tromsø. The people who come here don't want medication. This is their deepest wish. We say you can come to us. We want you as you are. Come to us with your delusions, your illness, your thoughts and feelings and history. Everything is good. We can meet them as they are. When people experience that, something essential happens. It takes away the mistrust and the fear and says to the person, this is okay. And then the person can start growing. That is the most important thing. This ward has been now operating for, I think, 8 years successfully. They also help people come off medications. There's the psychiatrist who's pioneered this. And look what they say when patients come off. The patients often report when they taper, they get problems back, but they find new ways to deal with them. These people have very strong feelings about getting their emotions back, and this is also experienced by their families. One woman told us, I thought I lost my husband 4 years ago, and now he's back. You'll say this. In Norway, there's a group near Oslo that works to take people off their medications. And these are chronic patients with multiple hospitalizations. And 5 years later, after they take them off, 16 are medication-free, 7 completely recovered. Now, there's a Psychiatry project that started up in Israel based on the Psychiatry project that was done by Lauren Mosher. Whoops. I don't know what I did there. Anyway, they now have this first one started in Jerusalem. I think it was in 2017. They now have either Psychiatry homes or what they called equalizing houses, where people, it's modeled after Psychiatry. The idea is that by being with people, going on, as you can see, go out for hikes, that can be therapeutic. They cook together, they live together. They're not locked into these home-like residences. Some people are on meds, some people are not on meds, some people taper off. And what they are finding is that so many people, in fact, get better. And now in Israel, a few years ago, they provide insurance for this. And it's becoming closer to becoming the standard of care. And it's based on this sort of selective use of drugs. So here's the UN High Commissioner for Human Rights. And here's what he says about what we need. Our ambition must be to transform mental health services, not just in their reach, but in their underlying values, so that they are truly responsive to the needs and dignity of the individual. And then it talks about supporting a rights-based approach. Now, I could go on with things, but what you see over and over again is forms of care that try to provide people with safety, meaning in life. There's a group in Connecticut, what they do with people, it's called Volunteers for Psychotherapy. And what they do is people who are basically poor, been released to mental hospitals, they will give psychotherapy, 2 hours of 1 hour of psychotherapy to people who come into the program. But in order to, quote, pay for that psychotherapy, the people have to volunteer. They can volunteer in animal shelters, deliver meals on wheels to the elderly, whatever it might be. And the purpose of that is this volunteer work gives the people a sense of meaning in life, a sense of purpose, an identity, gets them into social situations. And that is very different than always being seen as the person who's being helped. But it's an example of creating a new environment for the people. You see programs that emphasize exercise that are delivering good results. You see programs that, basically help set up a residential setting in nature where people work in the gardens and live with each other. Those help many people get well. And over, what you see is that if you create better environments, better diet, places for people to socialize, places for people to find meaning, and be with others. And I'm not saying everything goes great. I'm not saying that everybody gets well, but you do see higher recovery rates when you build better environments for people. And this should not be a surprise, because what do we all need? We do need meaning in life. It does help to have shelter. It really helps to have good social lives, to love someone and be loved. And so when we think about these calls for reforming mental health care, what we need to do is reject the disease model. It was a false model, and embrace this idea of that we humans are responsive to our environments. So how do we improve environments? So that's it. I'll close. I went a little long, but we'll have at least a few time for questions, and I will exit this.
Great. Thank you so much, Robert, for that extremely informative, if not shocking presentation. So we've got about 13 minutes left. So we will begin the Q&A. And if you'd like to ask Robert a question, you can raise your hand in Zoom. The instructions are in the chat. So Robert, first of all, how would people follow your work if they're interested in following what you do?
Well, obviously I did write a book called Anatomy of an Epidemic that sets out a lot of this. I also co-wrote a book called Psychiatry and Influence that talks about this corruption. But ongoing, I do run Mad in America, a website. And there you find a couple things. You find almost daily science reports that aren't promoted to the public precisely because they contradict conventional wisdom. But there'll be reports on long-term outcomes with antipsychotics for whatever disease. There'll be articles about whether these are validated disorders. And you also will find on the website resource pages. So you can go on menu bar drugs, and then there'll be a drop-down menu, antidepressants, and you'll get a nice long but succinct review of the literature I presented today for stimulants, for antidepressants, for antipsychotics, and links to the studies where you can then access the studies themselves.
Great, thank you. And in the time that you've been working on this, because it has been some time, has things gotten better? Do more doctors seem to be skeptical of the paradigm that they have been educated in and have been themselves promoting?
That's a great question. There is more skepticism. There is actually a lot of acknowledgement within the research community itself that this whole model did not pan out, and that outcomes, if anything, they haven't improved, and if anything, have worsened. Even Tom Insel, the former NIH director, said that. The chemical imbalance theory, at least in the research community, has completely collapsed. There's more and more acknowledgement that long-term outcomes are poor. A man named Nasser Ghami, a very famous psychiatrist, said we should only be using these drugs short-term. There's no evidence they provide a long-term benefit. So there is more skepticism towards that disease model story. And that is leading many people to be actually more cautious about prescribing drugs, and also to be, at least some, more supportive of people who want to withdraw from psychiatric drugs. So that is changing. The narrative has changed within the research community to a large degree, and there are many practitioners who are changing. However, the great majority of prescribers are still following that conventional model, using drugs right away as first-line therapies, antidepressants, antipsychotics, and not supporting people when they want to come off, and seeing any sort of bad outcomes as due to the disease and not to maybe the drugs worsening problems. So we're at this moment where a paradigm shift could happen. You have the World Health Organization, you have the United Nations saying we need to change this thinking. And you've had a long-term grassroots saying this really isn't working. And the research literature now is just filled with studies. You can come on to Mad in America that show these aren't validated disorders. The whole genetics search hasn't panned out. The chemical imbalance story didn't pan out. We really don't know. There are no biological markers. Even short-term symptom remission is not particularly good with these drugs. And more evidence showing that long-term, the best thing is if you can become unmedicated. Recovery rates are much higher. Now, not everybody can make it to that end, but that's what's showing up in the research literature constantly now.
Yeah,
it's so much more robust than it was in 2010 when I wrote Anatomy of an Epidemic.
Oh, that's good to hear. So, no, that's the profession itself. What about the general public and their skepticism, and especially in light of things like the opioid epidemic, where I think that I don't think there was any sort of defense, that was that the public bought. It was a little bit hard to obfuscate that type of thing.
So here's what happened with the public, the opioid epidemic. Everyone knows heroin's bad for you, right? So they were already primed to think that a drug that acts like heroin is going to be a bad drug for you and can cause overdoses. And when they say, and it's pretty easy to say, oh boy, they lied to us when they said it wasn't going to be addictive. So the public was prepared to accept the idea that, boy, we were bamboozled. The problem is that same skepticism has not been built up around psychiatric drugs. And the reason is, you can go to New York Times and not find any of the story I just told. You can go to the Washington Post and you will not find the story I just told. There's for whatever reason, the mainstream media is still cowed by the larger psychiatric association story about, yes, these are diseases of the brain. ADHD is a discrete disorder, and the drugs are safe and effective. And for whatever reason, and I do not understand that, and I'm a former newspaper reporter, they just will not report on all this literature that, in essence, undercuts the narrative that we have organized our thinking around. And I don't know why, but it may be that a lot of people, editors and all, they've organized their life around that story, and they're loath now to cognitive dissonance sets in to even consider information that counters it.
Well, and we've had people talk on this during this conference, that the fact that there is, that the pharmaceutical industry is advertising through these mainstream channels. They're not just paying to advertise, they're paying to control the narrative of the companies they're advertising through. What are your thoughts on that?
Well, basically, that's true. I mean, they say there's a wall between the business aspects and then the editorial functions. But you've got to look at what happened to media, right? Let's say newspapers. They lost their classified ads. They lost their display ads, and subscriber fees can never cover it. So, any sort of, and then TV, they need, so in other words, pharmaceutical funding of media, magazines in particular, and TV, go turn on your TV, there's pharmaceutical ads. Yeah, they have a hard time like cutting off that lifeblood. It makes perfect sense in this from a financial point of view. So yeah, pharmaceutical companies are making themselves indispensable to much of our media, which does prevent them from going after, say, psychiatric drugs or other things that may not be effective. And by the way, as I was on last night with John Abramson. Pharmaceutical companies are also funneling money to the research journals too. So they're not very eager to actually promote findings that are contrary to the sort of the marketing of these therapies. That's part of the problem. It's an information flow problem.
So we've had various experts talking on the concept of standard of care, where there's a protocol that doctors are either suggested that they follow, or that they are forced to. Like in cancer, you have very little leeway in how you treat patients. Is there a strict standard of care with how to treat these patients that doctors are not allowed to deviate from? Like, if someone is psychotic, are they pressured through a standard of care to prescribe this medication, or are they just bought into the model?
Well, many, of course, have bought into the model because they went through medical school and they were basically trained in this model and trained to think about these are safe and effective drugs and first-line therapies. Plus, that's what psychiatrists do now, right? They prescribe drugs. But with evidence-based medicine, if you have people saying these are the guidelines, this is what you should be doing. And remember, I went through who's setting those guidelines, people who are receiving money from drug companies. And they also have guild interest to promote. Once you have those guidelines, if you vary from the guidelines, like you don't give antipsychotics to a newly psychotic person, yeah, you're opening yourself to a claim of malpractice. You are, because you're seeing it's not providing standard of care. And there was a famous case in the 1990s with a depressed patient who wasn't given an antidepressant. And then he sued saying, I should have been given an antidepressant. And basically, there was this sense that you could be sued if you didn't follow standards of care. Now, often those suits aren't successful because doctors are seen as having leeway with their clinical use of things. However, if you're providing care in a larger system of care and you all of a sudden start challenging what everybody else is doing, you're going to be pushed out of that. They're not going to tolerate these lone wolves, so to speak. So this is part of the problem, that we actually do have an, quote, evidence-based medicine that is generated basically by the drug companies and promoted by people either working for the drug companies or promoting guild interests. And they're the ones that develop protocols. They're the ones that develop standards of care. And yes, you're a medical professional. It's really hard to break from those standards of care. Now, what's interesting, for example, the NICE, National Institute of Clinical Excellence in Britain, is saying don't use antidepressants as a first-line therapy for mild to moderate therapy. And that's partially because the pharmaceutical companies don't have the same influence they have there as they have in the United States, where you can advertise direct to the public.
So, and I realize that you're not a medical doctor or psychiatrist, you're a journalist, but are you comfortable in suggesting what the protocol is for people who want to wean off these drugs? Not that we're suggesting anyone should without the care of the doctor, but is there a protocol that you're aware of?
Well, actually, this again is now coming from the UK. Now, there's something called a Maudsley guideline. Now, Maudsley books are seen as very well-referenced books, okay? And for guiding medical care for a long period of time. And Mark Horowitz and someone else who was quite famous in UK psychiatry put together this textbook called The Maudsley Guidelines to Drug Withdrawal. So you are starting to see that tapering antidepressants or antipsychotics can be an accepted practice. And there are guidelines for doing it slowly. And if you follow those guidelines, as a professional, you should be okay. Because in fact, they have now been incorporated into guidelines to follow.
All right. So we have about a minute left. Are there any thoughts or anything that gives you optimism for what's going on in the future?
Yeah, I'm optimistic for two reasons. One, there is a growing chorus of voices saying this disease model has failed. We need to rethink it. That is up there. And when you have the World Health Organization and the United Nations saying we need a paradigm shift, that's a good moment of change. The other reason I'm optimistic, and there's a lot of grassroots we've had this thing for 43 years, it hasn't worked. There's a lot of people voting with their feet away from that model. And the other reason I have optimism is this: everything tells us that human beings are resilient. And then if you put them in different environments, you give them environmental supports, so many people can get better. Children can change their behaviors. And so part of the reason for my optimism is if we can have a paradigm shift that reconceptualizes this and says there's many pathways to psychiatric difficulties, but we know one thing: people are built to be responsive to their environment. And if we can create new environments around health, food, diet, sleep, social interaction, etc., we can have a system of care that will turn many of these problems back into episodic problems and help people, get their lives back together. Instead of what we do today, we pathologize people, tell them it's chronic, and that's what happens. They start seeing themselves as chronically impaired.
Great. Thank you so much, Robert, for all the information that you shared with us today. If we could unmute the audience so they can share their appreciation for Robert, please.
One-on-one. Thank you, Robert. You're my hero. Thank you. You've been my guide.
Presentation.